Then the last part in physical examination is auscultation. Here we are using our stethoscope. Before that, you have to note the normal auscultatory areas. The normal auscultatory areas in the chest are supraclavicular area, two supraclavicular areas, two infraclavicular area, then this is mammary area, two mammary area, then inframammary area. These are the normal auscultatory points in the anterior chest, then the lateral chest, supraaxillary area, then infraaxillary area. Then in the back, over the scapula, suprascapular area, two suprascapular areas, then this area, that is interscapular area, then two areas below, that is infrascapular area, two infrascapular areas. So infrascapular areas, infraaxillary area, two infraaxillary area, and two inframammary areas altogether from the base of the lungs. You will get the changes in the basal part on all these areas. So basically, all these areas are meant to find changes in almost all the lobes of the lung. That's the purpose of doing auscultation in all these areas. Altogether, there are 17 areas, normal 17 areas in the chest field. After auscultating, we can move our chest piece over different areas depending upon the suspected pathology. So that's the normal auscultation. Then the points we have to note in auscultation can be divided into three. First of all, we have to note the character and intensity of breath sounds, then vocal resonance, then third one is added sounds. So first of all, intensity and character of breath sounds. Here the intensity can be increased, normal or decreased. So normal intensity means normal breathing, or the patient is breathing normally. The intensity is increased in physiologically, there can be increase in the intensity, for example, doing exercise, running or climbing. Then pathological conditions like fever, thyroid toxicosis, etc. In all these conditions, the intensity may be increased. In children also, in lean subjects also, we may find the intensity is increased. Then the intensity may be decreased in obese subjects when there is large amount of adipose tissue under the skin, or fatty person. So intensity can be decreased. Then intensity is decreased during sleep also. So that's about intensity. Then the character of breath sound, we discuss character of breath sounds may be of two types: vesicular sound and bronchial sound. Again, when you auscultate, you will get normal breath sound. That's a feeble sound, or it is mainly due to the movement of air in the airways. This is due to movement of air in the airways. That's the normal breath sound. So two type of breath sounds can be there. That is vesicular sound and bronchial sound. Vesicular sound is heard by as a fine, low-pitched, fine sound, mainly heard over the peripheral areas. And bronchial sound is originating from the main passages mainly. And to know the intensity or the quality of bronchial sound or bronchial breathing, just keep the steth over your own thyroid cartilage, then breathe in and out. You will get a sound. That intensity can be judged as bronchial sound. Normally, you won't get that quality over the peripheral area in a normal person. If you are getting this type of sound in a peripheral area, then we can term it as bronchial breathing. If you get bronchial breathing in a peripheral area, then it is pathological. It happens, or it is seen in consolidation or lobar pneumonia, bronchial type of breathing. And normally, in a normal person, the respiration may be a combination of bronchial sound and vesicular sound. Towards peripheral area, it is vesicular, and in central area, it is more or less bronchial. So that's about bronchial and vesicular sounds. Or intensity and quality of sound is complete. Then the next point is vocal resonance. So we have done tactile vocal parameters in palpation. The same procedure. Here we are using our stethoscope, then asking the patient to say resonating words. Please say resonate. Please say 1 1 1 1.
1 1 1 1 1 1 1 1.
Examine all areas.
1 1 1 1.
Identical areas. You have to compare it. The sound. You have to compare the sound.
1 1 1 1 1 1 1 1 1.
Okay. The point in vocal resonance is that we have to note if the resonance is normal, the resonance is increased or not. So, how we can say the resonance is normal? That's the question. If it is normal, the sounds as if it is originating from the chest piece, and it is a blurred sound in the listener's ear or in the doctor's ear. That is a normal resonance. So if the person is normal or the lungs are normal, the sound is the resonating words the patient is saying is not so clear. It is a blurred sound and it sounds as if it is originating from the chest piece and reaching our ear. So if the resonance is increased, vocal resonance is increased, it happens in solidification when the lungs are solidified. For example, lobar pneumonia. In such case, the sounds become more clear. We can very well hear the sounds the patient is saying, or we can hear the 111 sound very clearly, and it sounds as if it is said inside into the listener's ear. That is called bronchophony. That phenomenon is called bronchophony. So here the resonance is increased. It is a pathological condition, bronchophony. So once you get the bronchophony, you can improvise that. That is, ask the patient to say the same words, or ask the patient to whisper the words. Just whisper the words. 1 1 1. Just whisper it. So, if the sounds are clear even during whispering, then we can confirm bronchophony. Okay, so bronchophony is there, whispering pectoral locking. Then one more modification to this procedure is egophony, that is nasal tone or like the cry of a goat. It's a nasal tone to the repeated words. It happens when you auscultate over the fluid level. When doing percussion, we have noted the fluid level. Suppose it is here, and we auscultate above that area, we will get the nasal tone to the sound. That is vocal resonance. Just close your nose. Just close your nose. Say the words loudly. 1 1.
What?
This is the tone. Nasal tone. This is called egophony. So when you note the vocal resonance, look for normal. Look which is normal or not normal resonance. Then increased resonance or bronchophony, whispering pectoral loci, and egophony. So these are the points in vocal resonance. So the last part in auscultation is added sounds. So what are the added sounds in respiratory auscultation? So basically there are 3 added sounds: crackles, wheezes, and pleural drop. In the old terminology, crackle is otherwise called crepitus or crepitition. Then wheezes are earlier it was mentioned as rhonchi. So wheeze or rhonchi, crackle or crepitition, then pleural drop. So 3 basic sounds are added sounds are there in respiratory auscultation. Regarding wheeze, is due to oscillation of the airways. This happens due to oscillation of the airways. It mainly happens due to narrowing of air. For example, in bronchial asthma or emphysema, it happens in the narrowing of the airways. There is oscillation. It's a fine musical high frequency sound. Then depending upon the sound quality, it may be polyphonic, then monophonic. Polyphonic means different frequency sounds you can hear. Monophonic means single frequency sound. Then the position may be throughout the chest or random wheeze. Random position, random wheeze may be there. Then sometimes suppose there may be a fixed wheeze, a particular position there, and the V's may be fixed. It won't change when the patient change its position after coughing or after lying down. If it is the position don't change, then it can termed as fixed V's. Then if the quality of sound is of single frequency, then it's called monophonic. Then fixed monophonic V's, you can say. You will get fixed monophonic V's in a few conditions, for example, foreign body aspiration, then cancers, or if there is any swelling pressing an air passage, or if the narrowing is permanent or fixed, you will get fixed monophonic V's. So that's about V's. Then inspiratory V's is there, expiratory V's, all this we can associate. Expiratory V's is classically seen in bronchial asthma and also in emphysema. Then inspiratory V's you get in bronchial asthma. Again, different situations are there when you get these different types of V's. Then regarding repetition, again, it is a wet sound or moist sound, bubbling sound. It happens when a closed air passage is forcibly opened. So it may be closed by, or the air passage may be blocked by secretions like mucus or blood or pus or something like that. Or if there is a blockage in the air passage and it is forcibly opened, we will get repetition. So it's a wet, moist, bubbling sound. So inspiratory, look for inspiratory crackle, expiratory crackle, look for position. Then if it is basal area or somewhere else, the basal repetitions are more seen in pleural, there's pleural pulmonary edema, then bronchiectasis, resolving pneumonia, like that. You'll get basal repetition. Then inspiratory crackles are there. Then late inspiratory crackles are. Late inspiratory crackle means you will get crackles towards the end of inspiration. It is typically seen in fibrosing alveolitis. Fibrosing alveoli is a fibrotic condition, and where you get late inspiratory crackles. So these are the different types of crackles. Then the last thing you have to note in auscultation is pleural drop. So there are two layers of pleura, parietal pleura and visceral pleura, and is separated by pleural fluid. So when there is pleurisy or when there is inflammation of pleura, so in the first phase of inflammation, naturally there will be a sedimentation or coating of the pleural surface with the inflammatory exudate. Then fibrin may be there and the surface might be rough. So there will be rubbing between two layers and you will get a peculiar rough grating sound. That is pleural drop. We can observe or hear it as pleural drop. It is a rough, grating, rubbing sound. We can differentiate it with the sound you get in bronchiectasis. In bronchiectasis, the sound is again a rough, it's a coarse, leathery, basal crepitus. In pleural drop also the sound is very rough, grating sound. But in pleural drop, invariably it is associated with chest pain. So in pleurisy, initial phase of pleurisy, when you get pleural drop, definitely there will be chest pain associated. So if there is chest pain and sound we get in auscultation, then it could be possibility is more to pleurisy or maybe pleural drop. So once the fluid is more, or when the condition is advancing or when the pathology is advancing, the pleura gets separated and pleural drop gradually disappear. The sound will disappear, but pathology might be advancing. Other symptoms might be there, will be like dyspnea, exertional dyspnea, or dyspnea might increase. So that's about pleural drop. You have to differentiate it from other coarse osculatory sounds. So altogether, in auscultation, we have to note the character and intensity of breath sounds, vocal resonance, and look for added sounds, if any. So that's about auscultation. So we have completed respiratory system physical examination. Thank you.